Okay, welcome everyone. Just give me a second here. Make sure that the recording has started. All right. Well, good morning and Happy New Year. I'm Brenda Rabel. For those of you who don't know me, I'm the technical director of Battelle's Partnership for Quality Measurement, and I am thrilled to welcome you all to our first ever PRMR Roundtable meeting. So this is a really unique opportunity for members from all of our PRMR committees to come together in one forum to share insights and provide input on a set of measures, both those that are currently in development and those that are already in use in other programs that align with CMS priorities and could potentially be expanded for use across settings. So as always, I want to sincerely thank you all for being here and for bringing your expertise to this discussion. Your perspectives are absolutely critical to all of our processes that help to shape measures that really do advance quality across programs and settings. So this meeting is going to look different from our usual PRMR sessions. We won't be doing roll call or voting for this call, for example. CMS, who you're going to hear from shortly, are asking for thoughtful feedback on each measure and measure concept, specifically what they could or should do to make these measures appropriate for cross-program use. Your input will help inform decisions that have the potential to impact quality measurement really broadly. So thank you again for your dedication and engagement. Let's just dive in and make the most of this exciting opportunity. We go to the housekeeping slide, please. So as you can imagine, we have a lot of people on the line today. So just to make the discussion as productive and efficient as possible, we ask that you keep yourself on mute throughout the discussion until you're ready to make a comment. You can use the hand raise feature to let the facilitator know that you'd like to chime in. And then once you're called on, you can go ahead and unmute yourself to speak. Once you've finished speaking, just lower your hand and remute yourself. If possible, do try to stay on video throughout the discussion parts of the meeting. It just helps to foster discussion and relationship building. And then finally, feel free to use the chat feature in Zoom to communicate with Battelle staff, or if you're having any technical issues with Zoom itself, definitely let us know via email at pqmsupport@battelle.org. We have folks that are actively monitoring that inbox, so we should be able to help you quickly. Next slide. So as for all of our PRMR meetings, we ask that you adhere to our community guidance, which means respecting all the voices that you hear today and doing your best to remain really engaged and actively participating throughout. Try to keep your comments concise and focused to the issues at hand. It'll just give you kind of the biggest bang for your buck in terms of how we can use that feedback. Be respectful and allow others the time and space to contribute. We ask that folks be generous and forthcoming in sharing your expertise and your experiences, and then, of course, taking the opportunity to listen and learn from one another. Next slide. We know that we live in an acronym-rich environment, which can be distracting for some. So we just wanted to include some of the most common acronyms that you might encounter here on this slide. Feel free to set this one aside for later if you ever want to go back and reference it. Next slide. So just quick introductions. There's my name up there on top. I'm Brenna Rabel. I'm joined today on the Battelle side by Jeff Geppert, who is our Measure Science team lead. And then, of course, Dr. Meredith Eastman and Kate Buchanan, who are your PRMR task lead and deputy task lead, respectively. They're also our co-facilitators today. And then Dr. Lydia Stewart-Arts, who is our evaluation lead and who's available to answer any questions you might have about the measure methodologies that in the materials that we've provided. And then on the CMS side, you're going to hear from Dr. Schreiber here in a minute. You'll also hear from Dr. Tara McMullen and Dr. Susanna Bernheim, both who are on the call today. And then, as always, I just wanted to acknowledge Helen Dollar-Maples, Nidhi Singh Shah, Shar Van, and Mel Gross for all of the work that they do to support us on this task. All right, let's go to the next slide. And with that, Dr. Schreiber, I'm turning it to you.
Well, good morning, and thank you very much. This is now our third day of the primer meetings. We've had 2 days of hospital meetings, and later this afternoon, we have the clinician and the post-acute care meetings. It has been action-packed, always interesting. I was saying earlier, I always learn something, and I expect that will be the case today as well. This is a somewhat different meeting, though, as was called out. This is really an opportunity to hear from all of the groups around the directions for making America healthy again. In other words, the prevention strategy for HHS and CMS. For those of you who don't know me, I'm Dr. Michelle Schreiber. I'm a primary care general internal medicine physician by background. I've had a lot of experience in healthcare systems. I've been at CMS now for about 7 years. I'm the Deputy Director of the Center for Clinical Standards and Quality and the Director of the Quality Measurement and Value-Based Incentives programs. It is really always a pleasure to hear from our stakeholders. And before we start, I just have to say a couple of thanks. First to Patel, who has done such a wonderful job over the last few days in facilitating and leading and putting these meetings together. And then also really to all of the CMS staff, our contractors, the measure stewards, who have also been on the call supporting this. And a specific call out, by the way, to Mel Gross, who from CMS has been the person helping to coordinate this. Mel, thank you. Today, again, we're going to talk about the strategy for making America healthy again. And that has many meanings to many people. And actually, we're interested in hearing what it means to all of you. We have some measure ideas, we have some measure concepts that we want to bring forward and really just open this as an opportunity to talk about future directions for CMS when it comes to prevention and wellness. We're going to talk about a few measures maybe that are in use already that we're looking to expand across to other programs. And here, if you think that's an appropriate approach, we're also going to present some other concepts to see how people feel about that. With that, we have just a few slides to share, but I'm going to introduce my co-presenters today, Tara McMullen, who is a PhD and has extensive experience in quality measures, and Dr. Susanna Bernheim, who is the Chief Medical Officer of the Innovation Center. For those of you who have been tracking this, the Innovation Center this year has been extremely busy, releasing a lot of new types of models, and many of these are around prevention. And so some of these concepts come from them as well. And I also want to acknowledge Tarun Amin, who has been working very closely with Tara in really leading some of the efforts across CMS of what is well-being, what do we focus on in prevention, how do we focus on this more holistically. So Tara, before we jump to slides, can I just check? Susanna, are you on the line? Do you want to make a few comments first? Did you guys promote her to speaker?
Let me try again. I'm here. Can you hear me?
We can hear you. Can't see you, but can hear you, Susanna.
We can
Okay.
see you. You're just kind of on the other end
okay.
of the, yeah, you're here.
Okay, great.
I will be very brief. Good morning, everyone. I have not been able to attend as much as I would have liked to of the last 2 days, but I have many years of fond memories of the interesting and important dialogue that happens at these meetings. So thank you, everybody, for being a part of the days before and this meeting today. As Michelle said, the Innovation Center put forth a new strategy last year with one of the pillars being prevention. So I and my team have been thinking about how that work manifests in our new payment models, and it's showing up in a lot of places, but quality measurement is obviously a key piece. And we've really thought, and Michelle and Tara are going to present about sort of how to focus on new aspects of prevention and strengthen efforts around primary and tertiary prevention that already existed in the measurement world. And we're thinking about new measure concepts. Today, you're here partly to weigh in on measures that are really being considered for CCSQ programs, but because the framework of this work and the work that we're doing to think about innovative measures is so related, my and my team are really excited to be able to be a part and listen to this conversation, and it will help us to think about the directions we go with new measures in the Innovation Center model. So again, thank you, and looking forward to the conversation.
Thank you, Susanna. Thank you for joining us. And Dr. McMullen, Tara, I'm going to turn this and the slides over to you.
Thank you, Michelle. Appreciate it. And Meredith, if we can go to the next slide. So hello, I'm Tara McMullen. Really excited for everyone to join us today. And thank you to everyone at CMS who has helped, and Battelle who has helped put these slides and this session together. Today, we have our first ever roundtable around some of these priorities in a session of this kind. Today, we focus on identifying measure concepts that align to the administration's priorities and the Make America Healthy Again framework. The discussion will center on key priorities of prevention, nutrition, physical activity, well-being, and obesity. These areas are critical, obviously, to improving population health and supporting patient-centered outcomes in general. The goal of the roundtable is twofold, as you can see on the slide. First, we look forward to hearing from our stakeholders, everyone, about the benefits and limitations of the measures that we are seeking comment on, and then also asking you to identify alternative measures or instruments for discussion and consideration. And secondly, CMS will take your feedback, build measure development strategies around your feedback, and hopefully inform future quality measure priorities with what we learned today. This process supports greater alignment across our programs and helps ensure quality measure efforts advance effective prevention, wellness, and improved outcomes. Next slide. Thank you. So the Make America Healthy Again framework represents a transformative shift in how health and wellness are approached. Rather than focusing solely on disease treatment, MAHA emphasizes a patient-centered care approach that prioritizes prevention, empowerment, and long-term well-being. This framework integrates primary, secondary, and tertiary prevention strategies to optimize population health outcomes through evidence-based clinical and lifestyle interventions. The framework, as you can see on the slide, reinforces the role of physical activity and nutrition as central components of preventative care, supported by evidence-based approaches in lifestyle and functional medicine, mental and behavioral health interventions, and the mitigation of upstream drivers of health. Overall, this model operationalizes prevention across the continuum, aligning clinical, behavioral, and social interventions to enhance beneficiary outcomes. Next slide. Thank you. So multiple initiatives and efforts across CMS are actively advancing the goals of MAHA. These efforts focus on strengthening prevention, promoting well-being and wellness, improving quality and patient safety, and advancing value-based, evidence-driven care. Through collaborative roundtables such as we have today, CMS is gathering stakeholder feedback to help support the development of strategies for healthier lifestyles, improved care coordination or coordination of care in general, and improved outcomes for individuals. CMS has established internal working groups to identify levers, interventions, whole person approaches, and measurement strategies specific to well-being and wellness, among other topics. CMS has launched the 13th scope of work to support healthcare quality improvement and the Secretary's MAHA initiative. As one of the largest federal funded quality improvement programs in the country, CMS directs the QIOs, as all of us know, to collaborate with healthcare providers nationwide to improve outcomes for Medicare beneficiaries. And CMS has launched models such as MAHA Elevate, developed under the intent of the CMMI 2025 strategy that focuses on advancing population health through three core principles: evidence-based prevention, patient empowerment, and choice and competition. Next slide, please. Thank you. To support the CMMI strategy and to build upon usable measures for CMMI models in general, CMMI has emphasized 5 key prevention domains, as you see on the screen: the absence of disease, the reduction of disease progression, function, health status, well-being, adverse events and acute care utilization, and time at home. This work supports a shift towards prevention and whole person care, laying the groundwork for future reforms. Next slide, please. And in closing, CMS is promoting the early review of 5 measures that align to the administration and national healthcare priorities. These measures reflect a shift towards patient-centered, prevention-focused care, emphasizing functional outcomes, nutrition, well-being, disease management, and preventative screening. By addressing these key health outcomes, these measures promote patient empowerment, they encourage healthy behaviors, and support improvements in quality of life across the care continuum. We conducted an environmental scan to identify both existing measures and current measures that are used in our programs and in models to help inform the discussion overall today. With this, we look forward to learning and hearing from you, learning how you feel about these concepts, if there are other important concepts that need to be identified, if we are not looking in the right area, if there are other concepts to take into consideration. And thank you so much. And thanks to Dr. Schreiber and Dr. Bernheim and Dr. Min. And I'm going to pass it back to Meredith.
Great. Thanks so much, Tara. So my name is Meredith Eastman. I am the pre-rulemaking measure review and measure set review task lead at Battelle. And I'm going to talk a little bit about the public comments on the roundtable measures. So we can move to the next slide. So we posted a separate written public comment opportunity on these measures and measure concepts on our website, concurrent with the public comment opportunity on the muck list measures. So we accepted written public comments from December 16th through January 6th. We also held 3 setting-specific listening sessions that I know many of you were a part of from January 6th to 8th to receive spoken feedback from members of the public on these measures and concepts. So we received a total of 71 public comments on these measures, including 24 spoken comments across all of the setting-specific listening sessions and 47 written comments on this set of measures and concepts. And we're putting a link in the chat to the compilation of those public comments so you can see what folks have said. And we won't belabor summarizing those comments as we move forward in the measure discussion, but we will certainly call out anything relevant that would help advance the discussion further. So we can move to the next slide. So before we begin our discussion of the specific topics we're going to cover today, we just wanted to set the priorities for our discussion. So as Tara and Michelle have said, we're interested in getting your thoughts on whether each measure supports stated Make America Healthy goals and how it fits within the primary, secondary, or tertiary prevention framework. We want to discuss cross-program applicability by evaluating which CMS programs could adopt the measure and hear recommendations about what modifications might be needed for broader program alignment. And lastly, we want to identify measurement gaps on these topics. So what are the critical outcomes or indicators that are not currently being measured? And we'd like to get your thoughts on any new metrics to strengthen impact and accountability in these areas. So I think we're ready to get started on discussion of these measures and measure topics. So I'll actually turn it back over to Brenna to get us started on the discharge function score.
Let's go to the next slide. Thanks, Meredith. And one more, we can go to the descriptor. Okay, so discharge function score. So this is a measure that is currently being used in the Home Health Quality Reporting Program, the Inpatient Rehabilitation Facility Quality Reporting Program, the Long-Term Care Hospital Quality Reporting Program, and the Skilled Nursing Facility Quality Program. And the purpose of this measure is that it's to evaluate whether patients achieve a discharge function score at or above an expected risk-adjusted level. It supports standardized functional outcome measurements across care settings per the Improving Medicare Post-Acute Care Transformation Act of 2014, or the IMPACT Act. We believe that this aligns with the Make America Healthy Again initiative in terms of its relation to physical activity and functional outcomes. It is an outcome measure type at the facility level of analysis. So I wanted to turn it over for CMS. Is it going to be Lenise that's going to say a little rationale for this one?
Yes, good morning. First, I want to introduce myself, which I failed to do before. My name's Lenise Cummings-Vaughn. I'm a geriatric physician and have been at CMS will be 2 years in February. I've experienced treating patients in all settings, inpatient, outpatient, the post-acute space, as well as nursing homes, just to give you an idea of my background. So CMS is seeking to gather comment on the concept of building a global measure of function. The discharge function score measure reports the percentage of patients or residents who meet or exceed an expected discharge function score. The expected or predicted discharge function score is calculated based on patient demographics and admission clinical characteristics. We choose this type of functional outcome measure in consultation with our technical expert panel to capture the wide range of patients or residents from which the goals might be maintenance in functional status, to others that might be expected to make large gains in functional status after orthopedic surgery. This measure contains data elements in the measure that emphasize movement, mobility, and self-care activities, reinforcing functional wellness and promoting walking and daily activities as foundational components of overall health and body function, all of which aligns closely with MAHA priorities. This measure was selected for comment as it has applicability beyond the PAC settings, the post-acute settings. The underlying data elements were tested in hospital and hospice settings as part of the Medicare post-acute care payment reform demonstration, as well as PAC settings. Prior analysis demonstrates that these data elements exhibit strong performance with robust discrimination of patient functional status and high sensitivity to clinical meaningful change, supporting their broader applicability. These data elements were later used in the IMPACT Act to inform the development of the standardized functional outcome set. The measure's flexibility, including its ability to be applied consistently across care settings while accommodating variation in patient acuity and functional status, makes it appropriate for uses beyond PAC. To summarize, CMS believes the cross-setting discharge function score measure will add an important and succinct way of addressing provider quality in a variety of settings, and we seek to solicit comment on the content and overall concept of the measure. Thank you.
Thanks, Lenise. Let's go to the next slide, please. Okay, these are not the only questions that we want to see folks answer, but just to give everybody something to kind of anchor the discussion. We kind of were interested, now that you've heard a little bit about the measure, in everybody's thoughts. So I'm going to open the floor, and maybe I'll just start by asking our patient participants for any initial thoughts on this measure. And if it would help to go back to the measure description, I can do that. Yeah, Reggie, go ahead.
Yes, this one I'm gonna go on an experience with my father who had a heart attack, and he had limitations regarding functions. And I think this measure, as it relates to having a clearer picture and a path for recovery, this would be a benefit. They didn't do discharge function score, but I think if they did, it would have improved or shortened his recovery time from that illness. So I just want to lay it out as a benefit of this measure.
Thank you, Reggie. And you were a little bit far from your microphone when you were talking. I think some folks had a hard time hearing you. Would you mind just retyping your comment into the chat for folks that maybe missed it?
Okay, I will do that. Sorry.
Thank you so much. Janice.
Yes, thank you for this measure. I know that having participated on other long-term services measures as a patient involved with measurement, that function often comes up. And I just know that in patient groups, patient family care partner groups that I'm a part of, function is really, really often the main concern. And so sometimes it seems to be secondary to other disease or conditions that come to the forefront. But something very important here too is, like, my mother had brain surgery where she had what's called normal hydrocephalus, and her, to understand the baseline is what I'm trying to say. So she had some mobility issues before she went in, so that it's important that people understand what the baseline is. Sometimes it can be improved quite a bit. Sometimes it might not be able to be, but I think this is very important and will be something that a lot of people, particularly in long-term care, short-term care, SNFs and such, will really appreciate. Thank you.
You, Janice. Anthony.
Yeah, I think this is a high quality measure, especially because it focuses on self care, which aligns with the Maha movement. And I think it covers all the bases for functionality and the three aspects that are most important when getting discharged. I think it should be utilized to its fullest. And I like the measure a lot.
Thank you very much. All right, Melissa.
Good morning. To everyone else's point, I really do like this measure. I have experience both as caregiver as well as in my day-to-day work. My one concern is for those patients out there who the goal is not to improve them, but just keep them from deteriorating further. Those with chronic diseases like an Alzheimer's dementia patient, a Parkinson's patient, that you may not be able to improve them. I just worry that facilities, care centers could try to prioritize patients that they can make a improvement in their measure, and maybe not so much in ones that they know that they're not going to improve, but that patient's goal is to stabilize and not decline, or not decline as quickly.
Thanks for that feedback. I'll just maybe follow up with a question do you think that that's something that could be addressed through changes to the measure specifications, like through exclusions or something like that?
I think through some exclusions right now, it's a very small list of exclusions. That, but also just how it's promoted, that the ultimate goal is not to always improve the discharge function score, and that there are patients that your goal is just to not let them get worse, or
And
to set them up for success, as they do continue to decline.
Melissa and Brent, if I can just interject for a moment, and Lenise may
Sure.
want to also. Your point is very well taken, and that's really why this measure takes into account the baseline status as well as the predictive sort of discharge improvement possibilities, because you're absolutely right. There are some patients where they're going to remain more or less at baseline. And so I think the importance of the measure is that it's able to determine the baseline score and how much improvement is actually possible.
Yeah. In my day-to-day job, you tend to hear, I work for a home health, and outcomes, you're always trying to improve. And, one of the things that I'm constantly saying is not everybody's going to improve, but people hear outcomes, they want to do better, they want to get their scores up. And, even if it's just in how it's promoted, versus trying to improve your numbers and hit certain scores. I think there's just opportunity there in how it's socialized.
Thank you.
Yeah,
Thank
it's a
you.
well taken point. Thank you. And there's some support for that in the chat I saw as well. I'll note that the floor is open for anybody who wants to comment. Now, I know I mentioned patients specifically up front, but I think we can open the floor. So Julie, go ahead.
Hi, Julie Marsnick, family doc hospitalist, here for the AAFP. So overall, I actually, I don't hate this. But my only comments are there's already a score that we're using in the hospital, or at least every hospital that I've ever worked in, called an AMPAC score. That is not an existing quality measure, but has, at least in my experience, been a fairly universally used equivalent to what we're trying to achieve here. And so I appreciate the ease of expanding on something that's already being used in other settings. But if you're looking to measure something comparable that's already being functionally used, it would be the AMPAC. Secondly, with the spirit of David Basil, I will point out that this has not been endorsed. I don't know what the risk adjustment methodology is, and have a lot of concerns with measures going through that have not gone through the CBE process to ensure that they have all the statistical everything in place to be appropriate. But all of that said, I like this. We're not always really great at keeping people moving in the hospital. It also acts as a bit of a balancing measure for our falls measures. And I think in our gusto to prevent falls in the hospital, we can implement some policies that prevent patients from keeping moving. And so on the one side, it's annoying to have two conflicting measures, but it's also a balancing measure in that regard.
Great points, Julie. Quick note to everybody who is commenting in the chat. Thank you. We love to see it. If you could make it just like in the line above where you type your message, there's a little drop down menu. If you could select everyone instead of hosts and panelists, just to make sure that everybody on the call can see your feedback, we would very much appreciate that. Christine, go ahead.
Get to my mute button. Hi, everyone. This is Christine Rager with KHS. I guess I have a question. So would the idea be to expand the measure? So this is a measure for the acute setting, to expand the measure and test it in other settings, as opposed to, just implementing it in another program, outpatient, primary care, et cetera.
It would probably, Christine, have to be modified for other settings. The real question is there interest in us using something like this in other settings?
Okay, great. And I would echo the comments about the need for potentially risk adjustment, but also supportive of the concept.
Thank you very much. Corinne, good morning. Go ahead.
I thank you. First, thank you for clarifying, because of my understanding too, the assignment was that this is an existing measure in the IRF setting, and whether the appropriateness for other settings of care like inpatient or ambulatory physician practice. So speaking, I'm going to really just speak to for use in the ambulatory setting. It is an important concept, although we need to see evidence first to support expansion of the measure to the ambulatory setting, and then whether a general measure on an individual's functional status is the best way to address the issue, or it is more valuable and suitable to have a measure that's more clinically disease-specific focus, and based on patient-reported outcome measures that that's targeted to specific population using validated surveys, as opposed to something generic. Routinely, we hear from physicians that they, based on their, specialty or practice pattern, when it does come to something like functional status, it's more appropriate and helpful to have something that's based on validated surveys that's connected to a specific disease.
That's great. I do want to note in the chat before I turn to you, Troy, we've heard a couple of interesting comments over there, and one of them from Michelle Dahl, I think is insightful and maybe a good question for CMS. So she said she's trying to picture this in acute care and struggling with how will a baseline be assessed at the point of admission, like, for example, when medically unstable, and it looks like it would maybe need a PT assessment. And so, a person may not be coming in at baseline because they're acutely ill. So how would the score be calculated in that setting, and how would it be used in that setting? And I don't know, maybe Michelle, if that's something that you wanted to speak to, or if that's just something that's worth considering later.
I think it's something that's worth considering. I think in a hospital setting, because there isn't the same assessment instrument tool that has been used in post-acute care, it would require thinking about it, and actually in the ambulatory setting as well, although probably easier there. It would require some kind of pre-assessment at some point in time, and then a post-assessment. That's why these measures aren't necessarily ready for prime time in other settings, but the concept of this is something we wanted to talk about.
All right. I am going to absolutely call on all of the hands that I see raised right now. I do want to say that we have a lot of measures to cover today. So I may not be able to get to every single person that has a comment on this. I would encourage folks to continue using that chat, because we will be collating all of that information in our recommendations. So if you don't get to say what you want to say about this measure, don't feel like you won't be heard. Please put it in writing. But Troy, go ahead.
Thank you very much, and appreciate the prior comments. My name's Troy Hillman. I'm from AMRPA. We represent over 800 inpatient rehabilitation facilities and have been extremely involved in the implementation and ultimate endorsement of the discharge function score. I just wanted to exercise caution in the expansion of this measure to other settings. First and foremost, we appreciate the concept of collecting functional status information at all levels of care, from acute care, ambulatory care, outpatient, inpatient rehabilitation, skilled nursing facility, et cetera. So we really like the concept of having functional status standardized, or the collection of functional status information standardized across all settings, in order to create that picture of the patient where function is a constant, right? It is something that we know how it's measured and what the ultimate values represent. However, as far as this function score measure is concerned, I want to again stress, during the endorsement process, we talked about the feasibility of this measure. This measure requires significant data collection effort, both at admission and discharge, of a number of data elements, not just those that are functional data elements, but again, there are over 100 different covariates for risk adjustment, such that you need to collect information on all of these in order to understand what the expectation is for the patient. This requires a very complicated software product to calculate these values, so that you gain an understanding of what that expected discharge function score may be. And again, from a feasibility standpoint, I find it very difficult, and we still find it very difficult within inpatient rehabilitation facilities to manage this measure and make sure that our performance is consistent with what the expectation may be. And then finally, I also want to note, there were complications with the publication, the public reporting of this measure for inpatient rehab facilities on Care Compare. So there are unintended consequences when the resulting calculations are not properly done or performed and suggest that performance is at a certain level. I'd note that the national average value for this discharge function score measure was reported at around 54 to 56% for a number of quarters. Once the calculation errors on the reporting were corrected, it's now showing somewhere north of 60 to 65%. So we just need to be sure that we're consistent and that all calculations, if this measure was to advance to other settings, is calculated properly and that providers have all of the necessary tools to manage their performance on this measure. Thank you very much for the opportunity to comment.
Thanks. That's great feedback in terms of what would need to happen for this measure for it to be appropriate in another setting, which I think is exactly the goal of the conversation. So very much appreciated. Carol, go ahead. Carol, are you?
Yeah, I'm sorry. I certainly support the emphasis on function, and I'm speaking as an occupational therapist who has worked with older adults in their homes for over 35 years. One of my concerns with this is how it would be expanded, partly because of the comments that were just made. The subcomponents, the functional performance that's being measured is done by direct assessment. It's not a self-report, so I have some difficulty thinking about how you would get an accurate function measure in non-inpatient settings or non-home setting, like an outpatient setting, that would actually capture performance. The other thing is in terms of how it would need to be modified. The actual performance that's captured in this item is really pretty basic. Being able to do oral care, being able to transfer to a toilet, being able to walk 10 feet, and being able to do basic grooming, which is sort of a minimum for someone to be able to stay in the community and would still need significant assistance in the community. So if this were to be expanded to other settings and potentially a broader population, I would think it would need a pretty significant difference in terms of what the components are that are part of the score in order to truly reflect function as it needs to happen for somebody to live in the community, and also to capture that piece of physical activity, because there's not a lot of physical activity associated with the self-care activities and mobility activities that are part of this measure. Thank you.
Yeah, great notes, Carol. Thank you. That's actionable. Okay, I'm going to give us the next three comments. So Jeff, Jean, and then Beth. Again, keep using that chat, folks, and then we'll move to the next measure. So Jeff, you go ahead.
Yeah, thank you very much. I'm a family physician, geriatrician, and of course think functional measurement is extremely important. However, I think one of the challenges here is where is the greatest value of using this measure? Where's the greatest opportunity for improvement? For example, in the ambulatory area, I believe this would represent a fairly large burden for mostly patients who are much more functionally intact than would be captured by this measure. So it has to be modulated according to the population being assessed, and some assessment of burden must be entered into the conversation. The other things that I'm interested in and concerned about are the ability to accurately predict what a observed versus expected. In other words, both the reliability and the validity of this measure in a broad range of conditions. Frankly, the breadth of what we see, particularly in primary care, but also in the acute care hospital, the correction, the methodology is extremely important and shouldn't be a black box. Finally, I'd like to note that measurement does not equal improvement. We measure a lot of things. Every time I go into the setting for my physician's appointment, I get asked about falls, about depression, about 107 other things, and it's all a checkbox. So with a effort to expand this to a larger population, I think we need to think that there is really some opportunity for improvement, and it's not just a measurement exercise. Thanks very much.
Thank you, Jeff. Jean. Oh, you're muted, Jean.
Great. Thank you so very much. Jean with HCD International. So especially with the consideration of expanding this, I would just ask that the non-medical drivers of health would be included in this because that certainly has an impact on the patient's, the patient's, future improvement. That's it.
All right, thank you. And let's wrap this one with Beth.
Sure. So I appreciate this measure and this idea of having a global measure, but I'm thinking what I thought what I was assuming, I think, is that we would look at the functionality the patient has during a time period and changes. And because I do think that when you are in primary care, you see a patient for 30 minutes and on that day, how they're functioning, you don't sometimes have this history. And I really thought that we were thinking that we would have information for primary care and patient-centered homes and that type of thing to really understand over perhaps the last year what the change in functionality has been and what the potential impacts if we were pulling data from skilled nursing visits and hospital visits and that type of thing. So I would just say I think there's really good ideas here, but thinking about how we can operationalize it, if you will, and really have impact for the patient is what I think would be a good discussion. Thank you.
Thank you very much. Okay, let's wrap up this conversation and we'll go to the next measure, but I want to thank everyone. This was the first time we ever did this. Lots and lots of feedback. The chat is about as engaged as I've ever seen it, which is wonderful. We'll be sifting through all of those comments and we'll summarize it in our recommendations later on, but I hope that CMS got some useful information from this conversation. I would encourage Michelle and others from CMS, if there are specific questions or things you want to follow up with, you can absolutely ask members in the chat to expand on thoughts. And with that, let's go to the next measure. Okay, I will pause on my facilitation duties and turn things to Meredith.
Great. Thanks, Brenna, and thanks everyone for getting us started on such a great morning. The next measure up for discussion is low density lipoprotein cholesterol, or LDLC, monitoring and management. And we can move to the next slide. Okay, so this measure is stewarded by the American Heart Association. I believe it is not currently used in any CMS programs. It's a new measure, has not yet gone through a pre-rulemaking committee review process. The purpose of the measure is to promote care for adult patients with clinical atherosclerotic cardiovascular disease, or ASCVD, ensuring patients diagnosed with this condition are tested for LDL-C and achieve an outcome of less than 70 milligrams per deciliter. So this measure calculates the percentage of patients aged 18 years and older with clinical ASCVD who had a low density lipoprotein cholesterol, or again, LDL-C, tested via lipid panel and who achieved an LDL-C of less than 70 milligrams per deciliter on the most recent test during the 12-month measurement period. The measure does include patients 18 years and older with ASCVD, and it excludes patients who are pregnant, who have end-stage renal disease, who are over age 66 plus with advanced illness, frailty, or dementia medications. So with that brief overview, I'm going to turn it over to, I believe, Dr. Dan Green to talk about the rationale for us discussing this measure today.
Thanks, Meredith. Welcome, everyone. Appreciate you all dialing in so early for some of you, especially on the West Coast. We do appreciate your comments and feedback. My name is Dan Green, as Meredith mentioned. I'm an OBGYN by training, and I work under Michelle Schreiber and Ron Klein on quality measures, particularly in the ambulatory program. So as Meredith nicely described the measure. This measure looks at the LDL-C level for patients who have clinical atherosclerotic cardiovascular disease, and it looks to achieve a target of less than 70. And so we're excited about this measure because it's an outcome measure. We currently have a measure in the MIPS program that looks at use of statin therapy per guidelines, which would include previous or current clinical atherosclerotic cardiovascular disease, a history of an LDL greater than 190, patient between 45 and 75 with diabetes, or a patient who's 40 to 75 with more than 20% chance of atherosclerotic cardiovascular disease. But unlike our current MIPS measure, again, that's just looking to see whether the patient was placed on a statin. This is actually looking for the results potentially of whatever treatment, whether it was a combination of statin, diet, exercise, what have you, but the patient was achieved a value to goal, which is again less than 70. We're excited about the measure also because we feel like this measure addresses some of the, at least 2 out of the 3 pillars of MAHA. So, and that would be primary prevention, because we're hoping that, again, treating patients to this LDL-C level will help to reduce their risk of heart attack in the future and stroke. And we're also looking at it as also treating a chronic condition because they already have established atherosclerotic cardiovascular disease. So with respect to the measure that we currently have in MIPS, we would be looking for potential ways to either harmonize or integrate this measure into that measure, which may or may not be possible. Some of the questions that we would have for the panel, and again, you're certainly not limited to these questions, so please feel free to make any comments that you have about the measure. But certain things we'd be looking for is, should we add this, if we were to adopt it in MIPS, should we add it to different MVPs, particularly the primary care MVP? Do folks on the call feel that this is such an important measure that we should consider making it mandatory? And then the other question is this measure suitable for use in other programs, perhaps post-acute care or home health? So again, not limited by any means to the questions I just posed, but certainly feel free to comment on those or any other comments you have about the measure. Meredith, let me pass it back to you. Thank you very much.
Great. Thank you so much. And as we open up the discussion, we do have a couple of additional questions on the slide. Please feel free to start wherever is comfortable for you all. I do see we have a hand raised. Matthew Parker.
Hello. Appreciate the information. I definitely agree to some of the previous comments made that in your example, the current MIPS measure and how it's focused on just the dispensing of a statin medication and not the actual outcome, that I do feel there is some room for improvement on that. My personal experience has been on the Part C, Part D STAR side. So we do have very similar measures that historically have been challenging because they are doing that very same thing. They are just looking at did the member get dispensed a statin medication instead of the actual measurable outcome of their LDL. Obviously, we run into a lot of challenges with that existing measure, such as lots of members with the myalgia exclusions where they can't take a statin, lots of instances where the member is paying a cash claim, so it's very hard to collect that data administratively to measure. So I do agree, and I do feel that this could be a good measure to extend also possibly the Part C stars as well, and really address some of those challenges like those statin-based measures that we've run into in the past as well. Just one other thought is I do suggest, and I'd be curious to know some of the more nuances in terms of the exact measured specifications. Especially, I'm thinking about, for instance, in HEDIS today for the controlling blood pressure measure, it's looking at the second diagnosis for hypertension once it falls within January 1st of the prior year up through June of the current measurement year we're looking at. So I do think it's important just to map out those nuances if they haven't been mapped out, just to make sure that there is actionable there is appropriate time in the measurement year to implement the intervention and then have an anticipated reduction in meeting that goal for the LDL.
Thank you, Matthew. Meredith, if I may hijack for just a second, to answer your last question, Matthew, this particular measure is looking at the most recent test in the 12-month measurement period. So if the patient's seen in January, obviously, a little bit at a disadvantage, but certainly if they're seen in December and the diagnosis was made in January, obviously they have 11 months to try to get that LDL-C under control. Thank you for the question and comment.
Great. Thank you both. Jeff Sussman.
Yes, thank you. I think this is a very important concept. I guess I wonder why we start with patients with ASCVD and how that is defined. It seems like one of the actual primary prevention efforts should be to prevent people getting to ASCVD, as opposed to starting with what I would call at least secondary or tertiary prevention of now trying to prevent the bad outcomes from whatever risk factor is present. So that's one thing. The second issue that I have is doing this at a provider or NPI level versus a group level. It seems to me that many times cardiovascular disease is a team effort. You're working with a primary care clinician, you're working with cardiology and perhaps other specialists, and that attributing the outcomes to a single person can be problematic and doesn't reflect how we really should be creating a team sport. So thank you.
Meredith, can I jump in one more time? I apologize.
Sure.
Dr. Sussman, so just to answer your first question about how we define the clinical ASCVD, it would be somebody with a history of acute coronary syndrome, history of an MI, angina, history of a stroke or TIA, peripheral arterial disease, or if they've had revascularization of a coronary artery.
Thank you.
Thank you.
Again, starting with that seems to me to limit some of the impact potentially of measurement related outcomes for preventing cardiovascular disease or further effects. Thanks.
Yeah, thank you, Jeff. And actually, your point is being echoed in the chat. A lot of folks are wondering if this could be broadened to include not just those diagnosed with ASCVD, but sort of move to earlier prevention. So your point is resonating very well. David Basil.
My point is one of alignment with payment policies, and so certainly supportive of aggressive anti-lipid treatment for many different populations that we've talked about. But my clinical experience has been that often this measure has getting the LDL down less than 70, and in many cases that means going beyond maximum statin treatment to other drug classes such as PCSK9 drugs, which on the payment side of Medicare can be very challenging, have very high copays, pretty stringent prior authorization processes. So if the administration feels that this is an important topic, which I agree with, then the payment policies need to evolve, not just the measurement policies, because you can't ask us to be responsible for this and then not pay for it on the back end, not pay for the medications that's going to take to get there. So the alignment on both sides of the fence have to evolve together if we're going this route.
Great comments. Thank you. Richard Heller, you are up next.
Well, I think I'm a moment late because I think that was sort of my point. I was only going to build on it, though. I think the ACC made some very good comments with respect to inequities, which build on what was just said about payment policy, that to achieve these results, you need to have access to advanced medications. And if we're going to have that as a goal, then patients need to have equitable access to those advanced medications.
Great, thank you. And I wanted to just sort of lift up a question that maybe Dr. Green could weigh in on. And this is from Wei Ying. There's questions about whether or not this would be a replacement for the existing statin measure, or would it be sort of used concurrently, or how would that relate to the existing measure?
Yeah, so thanks, Meredith. We don't have I can't give you a definitive answer, but certainly in the short term, it'd be much more likely that this would be a complementary measure as opposed to a replacement. Because if you think about it, and to a lot of the comments in the chat and those that were verbalized by some of the participants, be better to catch people before they develop ASCVD rather than, they already have the disease and now we're trying to do the best we can for them. So to that end, the current measure, looks to help prevent the development of heart disease, by treating, for example, diabetic patients who are 40 to 75 with a high dose statin, or somebody who has a history of a high LDL-C but doesn't already have established a clinical ASCVD as defined by the metrics I mentioned earlier. So again, I think at least at this point, these would be complementary as opposed to a replacement, because one's more prevention and the other one is more, prevention, but after the patient has established disease.
Great, thank you for that. Carol. Oh, Carol, I believe you're on mute.
Again. Okay, I'm sorry. I have a comment that's less about some of these specifics and more just this whole idea of an outcome measure like this. Having worked in settings where outcome, okay, let me say it differently. It seems like with a measure like this, and I can appreciate the comments in the chat, that so many of the factors are dependent on patient circumstances as well as patient health literacy and other things, that a measure like this, aside from all the other issues that have been raised, it seems to make more sense to target a change in a lab measure, for instance, instead of an absolute number. So, for instance, I work with a population where somebody getting down to cholesterol, a low LDL cholesterol level or bad cholesterol level of like 120 would be fantastic. And probably isn't going to get better than that because there are other life circumstances and other burdens on them. And that's a win for them. But saying, well, 70, great, 70 is ideal for everybody. But for the work that clinicians do to get them there, it just seems to make more sense when you're dealing with things, particularly in an outpatient setting, that are measures for a patient, that it should be about whether things are moving in the right direction rather than an absolute number that a good number of patients may never achieve just because of other circumstances in their life.
Great comment. Thank you, Carol. Lynn.
Good morning. Good morning from Northeast Michigan, in a very rural area where trying to put all this on the primary care clinician is really, really difficult, particularly when we're dealing with multiple areas of food deserts, areas that aren't safe for exercise. Like right now, actually, the sun is out, but it's the first time in a month. And we have ice and snow and all these kinds of things. So there's a whole lot of things that go into this discussion. And if we're going to talk about primary prevention, then we need to totally address the social determinants and social drivers of health, which include safety, access to safe, healthy food, the built environment, having adequate housing. And a lot of these challenges are true in rural areas, which are served, thank God, by FQHCs. And so consequently, they're working as hard as they can to help do the lifestyle interventions. And I mentioned in the chat that quite frequently the myalgias are actually PAD, and I don't think that there's been enough information on that in primary care. We're also understanding more about LP little a, which is a genetic component that needs to be addressed, and there's not a lot of treatment for it. The studies are in their final stages, but once again, it's being put back on the primary care clinic, which we can't do it all. We need some help with that. So that's my point. It absolutely needs to be done. We need to be able to exercise. We need to be able to sleep well at night. We need to be able to have good access to good food, exercise, be treated respectfully, reduce our stress, all these things. And I, as a nurse practitioner with 30 years experience in dealing with people with multiple complex diseases, can't fix it all. And I can't be responsible for all of it when the built environment and the infrastructure isn't sufficient to support prevention.
Thank you, Lynn, for lifting up the rural perspective, especially. That was great. I did want to call out a couple of comments in the chat, and folks are welcome to elaborate. I think this is getting back to what Carol mentioned about the threshold of 70 being established and integrated into the measure. Wei Ying has indicated that there was a similar measure under NCQA, and that the clinical community at that time indicated that it was problematic to set an absolute numeric target regardless of individual patient circumstance. So that would argue for, something like a 50% reduction or something similar, rather than a definitive target. And I wanted to also note Sarah Hooling's comment that there may be a benefit to broadening this measure. For example, if there's a better metric than LDL-C, perhaps it could be substituted for this one among, the patient population, just to give more flexibility in terms of how the measure numerator action is met.
Meredith, let me jump in with one last comment, which is
Sure.
probably more appropriate for this afternoon than this, but since a lot of folks will be on the same call, just to remind folks about at least the MIPS program. Currently, measures are being selected by the clinician to report. So, if this were too heavy a lift for certain practitioners, or was just one of multiple issues that they regularly deal with, they could always choose another measure, at least at this point. And also the second comment, we all, as medical people, we're all strive for perfection. I mean, everybody does, but especially as medical people, we're used to achieving, being high achievers, et cetera. But, at the same time, with these quality measures, I'd like to remind folks, nobody's expecting someone to get 100% score. We're looking, to trying to change behavior and for folks to make an effort to improve the patient's health, which of course is what the clinician obviously is intending to do anyway. So just want to make those two just general points. Thank you.
Thank you. And I think we are about at the amount of time we had allotted for discussion of this measure. So as you've been doing, please keep the conversation going in the chat. We will be collecting all of your comments. So with that, I think we can move along to our next measure.
Thank you so much, Meredith. And now we are going to be discussing the malnutrition care score. Next slide, please. So this is a measure that is stewarded by the Academy of Nutrition and Dietetics. It is a composite digital PQM intermediate outcome at the facility level of analysis. Deals with the priority topic area of nutrition. The measure was endorsed in 2024. And it is currently under consideration for 2 programs in the hospital care setting: the Hospital Inpatient Quality Reporting Program, as well as the Medicare Promoting Interoperability Program. The measure evaluates the quality and completeness of malnutrition care among screening assessment, diagnosis, and care planning. It promotes early identification and coordinated multidisciplinary nutrition care. The total malnutrition care score reflects completion of appropriate steps based on patient risk and status. And here you can see the 4 components that lead to the measure score: the risk screening, nutrition assessment, malnutrition diagnosis, and nutrition care plan. The measure population and exclusions, it is for adult inpatient hospitalizations greater than or equal to 24 hours for people 18 years of age or older, and it excludes hospice encounters. I will turn it over to Dr. Marcia Smith at CMS to provide some additional CMS context. Dr. Smith?
Kate. Thank you, Kate. I'm Marcia Smith. I'm a medical officer in the Quality Measurement Value-Based Incentive Group. I'm a pediatrician by training. I've been in the federal government for 16 years. I have experience in various settings, local, state, government, and I am an avid public health fan. So this whole session is near and dear to my heart. I wanted to make a correction though. The malnutrition score measure is actually already in the IQR program. And it was on the MUC list because it's being added to another additional program. The changes that were on the screen were related to the changes in the population that was included. It has been expanded from just 65 and older to 18 and older, and that was finalized in fiscal year 2025 final rule. And as I mentioned, it was on the MUC list this year for addition to the PPS exempt cancer hospitals. This measure assesses the percentage of hospitalization for adults age 18 and older at the start of the measurement period with the length of stay greater than 24 hours who received optimal nutrition care during their hospitalization, where care performed was appropriate for the patient's level of malnutrition risk and/or severity. Malnutrition care best practices recommend that for each hospitalization, adult inpatients are screened for malnutrition risk, assessed to confirm findings of malnutrition risk, or a dietitian referral order, and if identified with a moderate or severe malnutrition status in the current performed malnutrition assessment, receive a moderate or severe malnutrition diagnosis and have a care plan performed. Currently, acute hospitals and critical access hospitals voluntarily report this measure, with 81 facilities reporting on the measure in 2024, the first year that it was available. It is one of the 3 optional ECQMs hospitals may self-report. They self-select these to report in addition to the mandatory 5 ECQMs for a total of 8 that they must report. We are considering adding, as I said, it's already been discussed on the PPS exempt cancer hospital quality reporting program for the upcoming rulemaking cycle. In addition, we are considering extending this measure to other hospital settings and the post-acute care program, as it will promote better nutrition, which is an important component of American health, as well as enable better quality improvement assessment across CMS programs. Identification and remediation of malnutrition risk prompted by this measure promotes a shift away from sick care in helping identify at-risk patients, encouraging continuity of care, reducing risk of future readmissions, and improving quality of life. We're looking forward to the discussion and receiving your inputs, feedbacks, and suggestions on the validity of expanding this measure to other settings. Thank you.
Thank you, Dr. Smith. And if we move on to the next slide, you can see we have a couple of questions if it aligns with the Make America Healthy Again objectives. Could this be expanded to other CMS quality programs? Dr. Smith highlighted its use in additional hospital programs as well as in the post-acute setting. And are there other measures that should be adopted to better address this concept? I see, Jeff, you have your hand raised.
Yeah, thank you. So I, of course, support the idea of identifying malnutrition, but I have concerns about burden. Our hospitals have cut back significantly on dietetic support, people who have the training necessary. I also worry that this is a measure of process rather than any sort of outcome. So a care plan is developed, then they go off into their community and nothing happens. Or a rural community where there might not be the resources available, or inner city. So I support the concept. I just worry about it being applied to all inpatient admissions and having the feasibility here to really execute it, and then will it really influence outcomes that are important to patients? Thanks.
So just to clarify, it's already in the inpatient quality reporting program. And the ask here is regarding expansion, and appreciate your feedback regarding concerns for rural hospitals. This is an ECQM, and there's actually the primary thing is the assessment of the malnutrition status of the patient, and making sure that they receive the appropriate assessment and plan that they can. And there is actually the ability to engage dietitians through digital means and things like that if they don't have the people, the folks on staff. So I just wanted to jump in and say that it's already in the program. Critical access hospitals are reporting it, and just wanted to make that clear.
So just to clarify then, Dr. Smith, what is the change, or what is the expansion that's
we're asking for other settings? Like right now it's in the acute hospital setting. We added it to the MUC list for addition to the PPS exempt cancer hospitals. And so the ask here is we're considering adding it to the post-acute care setting. Is that appropriate? Like, what are your suggestions, inputs, or are there other measures that we could consider to align with the MAHA objective of nutrition? Over.
Okay, thank you.
Thanks. And I will note that we had a comment in the chat saying that if this is applied to other facilities, there could be considerations around exclusions, especially for inpatient psychiatric care, excluding people with a diagnosis of anorexia nervosa. Christine.
Yeah, so I agree that this is an important measure for the inpatient setting, and would urge the consideration of malnutrition being captured in the outpatient community, long-term care, home health settings, as well, with consideration for social drivers of health, and then also thinking about coupling this measure with an outcome measure, as was mentioned.
Thank you. Carol?
Yeah, my ears perked up on the comment about considering adopting in post-acute care, particularly in home care, because the supports that are available in the inpatient setting are not available once someone lives in the community. That include. I have worked in the home, and we've had people go to the hospital who would be identified as malnourished, and we knew that. But the services, supports, and benefits outside the hospital are entirely different than in the hospital. And so, for instance, if a patient needs tube feeding or supplements, things like that, they're either not covered, or you can get into insurance kinds of situations where the person can't get what they need. And so I appreciate the value of this measure in the acute setting and in an inpatient setting. But the reality is there are people who come in who are clearly already malnourished, and they're malnourished because of food deserts, because of the food that's available to them, or other circumstances in their life. And it's great to identify them as being malnourished and do something in the inpatient setting. But as soon as they leave that inpatient setting, even if they had telehealth support, say from a dietitian, the benefits, the services that are available to them for malnutrition or malnutrition risk to be reduced or addressed don't exist. And I think that's a much larger issue than just simply whether or not malnutrition care is implemented over what's relatively a short-term healthcare stay.
Thank you. And I see we have two of our committee members with their hands raised, as well as the developer. I'm going to go to David, Teresa, and then I'll go to the developer. David.
Thank you. So again, my comment is around alignment between the payment side of the fence and the measurement side of the fence. And so going in HCC risk score adjustment going from version 24 to 28 recently, malnutrition actually got dropped as something that adjusts the risk score. And so at the same time that CMS is saying that we value malnutrition, on the payment side of the fence, they said we no longer care about malnutrition. And so just alignment between those two things, I think, would be important. And people pay attention to those HCC scores and monitoring those, and that it's a very effective tool that probably is even more effective than the measurement side of the fence.
Thank you. Teresa?
Hi, everyone. I'm on today representing the Advancing Excellence in Long-Term Care Collaborative, and we sought feedback from a few of our members on this and the other MAHA-aligned measures. So for this one, in the nursing home setting in particular, our members generally support inclusion for long-term care residents, but think for residents with very short stays that this may be less appropriate. Nutrition assessment and care planning is definitely a part of what nursing homes are required to do as a part of delivering care to their residents. So this definitely aligns with what nursing homes are already trying to do. But as we think about the appropriateness of the measure for that care setting, maintaining the exclusions for patients with a terminal diagnosis, or for those who increasing oral intake doesn't necessarily align with what matters for them, in person-centered care may be less appropriate. And of course, addressing medical conditions like anorexia and things like delirium too, where we know nutrition plays a big role in hydration in delirium. So as we also think about what counts as part of care planning, things like feeding assistant, shared decision-making around aspiration, are scenarios where there may be some significant issues with malnutrition. So as with many things, the details are important. What counts as a care plan is going to be critical for this setting.
Thank you, Teresa. I appreciate it. Throw over to Angela with the developer.
Hello. Thank you all so much for this discussion and for giving us an opportunity at the Academy to address questions that you have. As you guys know very well, nutrition touches everyone, and it touches them in very different ways. So Teresa, to your point, I appreciate what you said, because it brought to mind that nutrition care and malnutrition care isn't just about increasing oral intake. And I think that's one of the reasons why bringing dietitians to the forefront with this measure is so important, because there's so many different aspects of improving malnutrition beyond just that. And I think that's why dietitians are nicely positioned in this measure. As far as burden and kind of like the rural aspects, I definitely appreciate the comments around that. Prior to my current role, I was a clinical dietitian for 24 years in long-term care, large acute care hospital and rural hospitals. So I know the complexities of that. I know the varying availabilities of dietitians in different settings. And I do feel like that's improving over time. And I feel like that is also one of the reasons why it would be really important for this measure to expand into other areas, to highlight the need for nutrition to be just as much of a priority in those areas as well. Also, from personal experience, I know like the transitions of care area, and just recognizing those gaps, trying to fill those gaps between the hospital, long-term care from home as well, is is quite challenging and definitely needs to improve. I think some of our work with interoperability will help improve that as time goes on as well. But I'm not sure if I captured all the questions, but my team is also answering questions in the chat as well. But thank you for this opportunity. I don't want to take too much time.
Thank you, Angela. I really appreciate it. And I appreciate that you called out that you guys are answering questions in the chat. Tamari in the chat is also answering questions. She's replying all to everyone. So please just keep your eyes out. Beth.
Sure, and thank you. And the one thing I did want to say, so I work for an acute care system, and this is a measure we've been working on. And one of the things that I have some sensitivity to is how it will be reported to the public, because essentially this is really a measure about process. Did we screen and did we identify and did we put a plan in place? But when we're talking about a patient population that often has an average length of stay around 2 to 3 days, our ability to actually impact malnutrition, which is a very complicated and long-term situation, outcome is very limited. And so, but I think when you put a measure out there that talks about malnutrition and then link it specifically to a hospital, that there can be a lot of misunderstandings about this measure. So I just share, I think that we do have to be pretty thoughtful about the reporting of this measure and making sure we really understand what it's measuring. Thank you.
Thank you, Beth. I appreciate it. I just wanted to say that we are looking at the chat as well, and there are a lot of notes about access to food as well as other determinants that may impact someone's ability to get access to food. We're taking note of all of those, so did want to say that these comments are being recorded. I am going to raise up a comment from Michelle Dahl, which is echoing concerns around the impact of this in the inpatient setting. And it's she has a frustration, the amount of patients that she has keeps finding on prolonged inappropriate NPO status, waiting for procedures. And those with a special meal, patient does not have dentures with them or assistance with meals needed that are not addressed. And so they find that this measure might not be addressing some of those issues, but is challenging sometimes within the inpatient setting and not addressed. Okay. And I am looking through, and I don't see any other hands raised. We do have some comments coming through, but I think that we can move on to our next measure.
Great. Thank you, Kate, and thanks everyone for continuing the conversation. The next measure we're discussing is preventive care and screening, body mass. Oh, I'm sorry, Lynn, did you have a comment about the previous measure?
No.
Okay. You just wanted to be first in line for this one.
Yeah, I have to leave, and so I just really wanted to put a little dot on that T. So
okay, I'll get through this quickly. This is the preventive care and screening BMI screening and follow-up plan measure, and we can move to the next slide. So this measure is stewarded by CMS. It is being submitted without substantive changes and is currently in use in MIPS and in the Medicare Shared Savings Program. It promotes routine BMI screening in adults and appropriate follow-up plans when BMI is outside the normal range, and supports early identification of obesity-related risk and referral to evidence-based interventions. It counts patients with documented BMI and, when abnormal, a documented follow-up plan. Follow-up plans may include counseling, referral, or treatment aligned with clinical guidelines. The measure population is adults 18 and older with a qualifying encounter. It does exclude pregnancy and hospice palliative care, and it allows medical inpatient refusal exceptions. This is an ECQM, and it's a process measure. And with that overview, I'm going to turn it back to Dr. Dan Green.
Thanks, Meredith. I'll be very brief with this. We do think that this measure is consistent with the MAHA objectives in that it it addresses prevention from the standpoint of people have a large BMI but don't have established secondary disease related potentially to their weight. The idea would be to get them obviously in better shape before any of those things like diabetes, heart disease, hypertension, et cetera, set in. So as everyone knows, obesity is an epidemic in our country. And we think it's an important topic or condition to focus on. The measure, as Meredith stated, was placed in MIPS in 2017. It has been now relegated to MVPs. It's currently in 5 MVPs, including the Advancing Care for Heart Disease, Improving Care for Lower Extremity Joint Repair, Quality Care for Treatment of Ear, Nose, and Throat Disorders, Rehabilitative Support, and Pulmonology Care. And again, as a broadly applicable measure, there are many other MVPs that we could consider placing this measure. Again, at present, it is as all MIPS measures are, a voluntary measure. And we look for comments in terms of expanding the use of the measure, either in MVPs or in other programs, or other comments that you may have regarding the measure itself. Thank you, Meredith.
Great. Lynn, go ahead and we will move to the next slide.
I'm actually quite passionate about this one because obesity is a disease. It's not a condition. It's not prevention. We're moving into secondary and tertiary prevention with the diagnosis of obesity, number one. Number two, BMI is not scientifically supported. We don't have a good measure. Waist to hip ratio is actually much better than BMI, but the feedback that I get is we don't have the time to do that in the office. So part of what we're doing is supporting a measure that's not valid, and we need to be focusing more on developing a measure that is valid is adaptable to the clinical measure or clinical situation. Thank you.
Great comments, Lynn.
And can I just comment back to Lynn for a second, Meredith? And we recognize that controversy, Lynn. As we were looking, though, there isn't another great widely applicable tool, but I will tell you that the quality improvement organizations will be working with select facilities and clinicians kind of testing out things like waist to hip ratio or other ways of measuring that we could use in the future. But at the moment, this is what we found that is the most widely applicable.
It's widely used, but not necessarily widely applicable. I'm going to agree to disagree with you on that one, and respectfully so. But there are multiple organizations that are working on developing a measure, which I'm very thankful for.
Great. Thank you. It was important dialogue to have there because many of the public comments about this measure echoed similar concerns that Lynn raised. So thank you for raising that early on in the discussion. Deirdre.
Thank you. I had a question, a clarifying question about the exclusions. If I understand correctly, the patient can decline being weighed. Can the patient decline a follow-up plan? And the reason I ask is that I worry about patients of higher weight who report being dismissed in their other symptoms because clinicians will focus on, well, if you lost weight, it would be better instead of like getting to something that could be a safety event or misdiagnosis. And I just wondered if it would meet the measure positively for the patient to say, no, I don't care to talk about that. I don't want to talk about a plan, follow-up plan. And if that would count, as a achieved so that the patient's, preferences are honored.
Great question.
Pam, are you able to answer that? I don't have that information right in front of me. I don't think that they can decline, but I'm not 100%, Deirdre. We can get back to you on that.
Yeah.
Pam, unless you know.
I'm pulling up this back. I can put a response in the chat.
Thank you.
That seems to me that it would be important to consider so that patients, even if it's appropriate for the patient to receive that follow-up plan, if patients have a lived experience of every time I go to the doctor, they just tell me I'm overweight, I think that can dismiss trust and dismiss willingness to seek care and can cause safety concerns and delays in diagnosis. Thank you.
Thank you for raising the question. We'll look for an answer in the chat. Jeff.
Yeah, thank you. First of all, I would agree with the lack of scientific rigor around this measure, the validity issue, and continuing to use a measure that is flawed, I think perpetuates things like stigma that has been raised and may or may not be helpful. The other issue is that we have a new class of drugs. It's being used by all kinds of people who want to have their weight. And BMI may or may not be the best way to follow their progress. Concern about loss of muscle mass, for example, the inability to really get to visceral fat, things that we know are probably more important. So while widely used, easy to use, I'm not sure we should perpetuate what I think is half-baked science. Thank you.
Thank you so much for that perspective. And I do see some agreement with your comments in the chat as well. I did want to pause on a couple of comments that came in earlier on in this discussion, raising questions about how this measure would handle patients with low BMI, or would this, potentially screen for, or should we potentially screen for the other end of the spectrum as well? And I'm just going to keep scrolling through the chat. Teresa, yes.
Hey again. I just want to echo the importance of, if we move forward with BMI, ensuring that it includes screening for abnormally low BMI in addition to high BMI. And as the current measure is specified, I believe it does exclude 65 plus with contraindicated conditions from this measure. I think that's going to be appropriate, especially in the long-term care settings. And it really needs to reflect age-appropriate care, and things like infection resistance and wound healing should be prioritized over weight loss and overly aggressive BMI management, especially in the population that is in post-acute and long-term care.
Great comments, Teresa. Thank you so much. And I do have a question in the chat from Annette Kaiser about what tool is used to classify someone as having a higher than preferred BMI, and some other folks asking about a layer of verification before using an overweight classification based on BMI. Okay, I'm not seeing. Oh, we're getting a few more comments in the chat that I don't want us to miss. Jeff Doherty, did you want to speak your question or your comment aloud, rather?
Yeah, sure. I'd be happy to provide a dramatic reading of that one. I guess I really worry here that we're missing the forest for the trees, in that I agree that there are challenges with BMI as a measure of adiposity, but the fact is that excess BMI is associated with a wide variety of negative health outcomes, and there's measurement error in every lab value and measurement assessment that has ever been put forward, and the question is whether the measurement is useful despite that level of measurement error. And in this case, I think if we weigh the potential harm of providing counseling and potentially referral to people who have high BMI because of excess muscle content versus the risk of not providing those resources to people who have high BMI because of excess adiposity. The challenge becomes clear, which is that the excess BMI due to adiposity is far more prevalent than that from excess muscle, and not providing those people with the resources they might need to avoid some of the health consequences is clearly not the right choice in this case.
Thank you for that important counterpoint to some of the comments that folks have been making. So I think I'm not seeing any other hands. I do, of course, encourage people to continue using the chat, but I think we can move on to our next measure.
Okay, I think that's my cue.
Yeah, good. Well, actually, Tara, let me jump to the description slide so that we all have it on there.
Thanks, Bren.
Yeah, of course. So this is the well-being signs measure. It's a VA measure. It's new, so it hasn't been reviewed prior to this by any MAPR primer committee. It's not yet in use. But the purpose of the measure is to assess whole person well-being, focusing on what matters most to patients. And it's supposed to expand quality measurement beyond disease-specific outcomes. And the measure works by looking at all active patients who complete a brief patient-reported well-being instrument. And then the performance is based on the completion rates, and it uses a total WBS score only. So it's a very broad-based measure. And with that, Tara, I will turn it over to you to give the CMS rationale.
Thanks, Brenna. Yeah, and hi, everyone, again. So as Brenna just illuminated, this is a newer measure in concept. We were in construct, and we are seeking feedback on the concept of this measure and just your thoughts about this measure. So out of the box thinking about well-being. To get started, CMS, we're seeking input on the feasibility of the approaches around this measure as it supports MAHA. So for today's discussion, we define well-being as a key prevention and MAHA outcome reflecting overall quality of life and how individuals feel and function across emotional, physical, psychological, and social domains. We distinguish in this discussion well-being as an outcome reflecting overall quality of life from that of wellness, which we refer to as an ongoing process of lifestyle choices and behaviors that support health. So for this discussion, well-being is increasingly recognized as a critical outcome of healthcare, yet it remains challenging to measure in ways that are both meaningful to patients and feasible for routine clinical use. Existing measures often focused on either disease-specific outcomes or on distal concepts of well-being that are less actionable for care delivery. So CMS is working towards steps to define and establish a common framework for assessing and measuring beneficiary well-being to inform, track, and optimize positive outcomes. While multiple measures assess aspects of whole person health or well-being, today's discussion will focus on the application of the Veterans Health Administration's Well-Being Signs measure. So again, a newer measure, the Well-Being Signs provides a brief, patient-centered snapshot of how individuals are doing in their everyday lives, focusing on areas that matter most to them. The measure is based on 3 connected but distinct aspects of well-being: participation in meaningful roles and activities, functioning within those activities, and overall satisfaction with how things are going. The measure includes 3 brief questions scored on a simple numeric scale, making it easy to use in busy clinical settings. Studies show that well-being sign scores are reliable, meaningful, and able to detect important changes in the patient over time. And this provides information that's complementary but does not duplicate traditional health measures. The Well-Being Signs measure is currently used in 133 VHA facilities nationwide and administered through multiple modalities such as face-to-face, virtual visits, and telephone encounters. Electronic administration is also used, and it's grown substantially in the VA system. Most staff administer well-being signs based on their clinical judgment or the context of their visit with the patient. So while we, CMS, are seeking feedback on well-being signs, we also invite your input on novel well-being measurement approaches instruments, measures, concepts in general, that you consider reliable and valid. And today, just want to note that we are joined by our colleagues from the Veterans Health Administration. So thank you for that to our colleagues. This is an important discussion. We thank you for your input, and the input that we gather will help build our strategic roadmap here at CMS around well-being. So thank you so much.
Thanks, Sarah. It's a great, I think, primer for this conversation. So again, emphasizing to folks that what we're really looking for here is feedback on sort of what it would take to make this something that's, broadly applicable in CMS programs. So with that, Jeff, go ahead.
Hey, thanks. So I think the concept of well-being and the idea behind this, I'm very supportive of, but I have a very hard time thinking of how this would be operationalized and deliver actual value given the diversity of impacts on well-being, ranging from social determinants of health, income, location, things that the individual clinician, if this were targeted at that level, have very little ability to impact. So while I think it's a useful concept, until I saw a measure that was actually important to patients and amenable to impact from the clinician side, I would be very skeptical. Thanks.
Thank you. Rosie.
Well, I guess I differ because from a patient's point of view, asking a patient what matters to them is really important. And it's those kind of things that, what gives you meaning, what keeps you up at night, those kind of answers really make a difference to the patient's well-being in the end. And, when a clinician asks me, what am I doing, across the healthcare systems and what am I working on, or that gives meaning to me. And that's important to me. And, when older adults are dealing with many, many hours of loneliness, asking them or helping them to look at what gives meaning to them is really, really important. And, the whole What Matters to You movement across the country and the world has really brought meaning to patients in all kinds of settings. Thank you for giving me a chance to support What Matters to You.
Thank you, as always, Rosie. Deirdre.
Thank you. Conceptually, completely aligned with the topic of the measure, agree with the prior comments about what matters to you. I have some concerns in terms of the how to expand some things that I think need to be taken into account. Realizing that this is a preliminary discussion, I didn't find a lot of information about the validity testing of the measure. I did some Google searching on my own. I think that would be really important to ensure that before deciding if the measure is appropriate, like, is it a measure that measures something that that we think we can document in the way that we would need to. More importantly, in the documentation that I saw, it said that all data elements were in the EHR and there would be no workflow changes, which I think is misleading. I think it's inaccurate. There might be, the EHR might include the things that you need to know to identify who could receive the measure, but administering a patient-reported outcome measure takes, like, first of all, you would have to actually administer it to get the data elements to calculate it. And there would absolutely be changes to the workflow that would need to be specified. Is it oral? Is it electronic? Is it during care? Is it after care? And those parts, I think, certainly could be incorporated into other CMS quality programs. But as patient-reported outcome measures have expanded, which I am fully for, like, that is my favorite thing, patient-reported outcome measures, but we are not being careful about harmonizing those. So if this is going to be expanded to other measures, there has to be really clear line of sight of what other patient-reported outcome measures are being asked, when and in what modalities, and how could this measure be incorporated into those methodologies instead of yet another outreach that could actually diminish the likelihood of patients responding to any of the measures that exist today. So some methodology considerations for us in the future. Thank you.
Thank you. And I want to just sort of summarize, we're hearing a lot in the chat and also here a lot of, general comments about survey fatigue, about trying to harmonize with existing tools and measures, trying to make sure that, we're not adding burden to patients or making yet another measure that kind of becomes rote. I do want to ask committee members, as you're thinking through your comments here, like, if this measure were to be used, like, what setting would it be the most beneficial? And I think I've seen some comments in the chat where people are asking, like, what it's being considered for. And I think at this point it's wide open, and we'd be interested in hearing from you. Where might this be most feasible? Where might this be most impactful? And what would need to happen for that to be the case? So with that, Carol, go ahead.
Brenna, can I just intercede for one moment? I know there are a lot of people who have comments. Would it be also useful, we have people from the VA on the phone, for people to hear their experience of how they've used it, because CMS hasn't used this in any program, and I think people might like to hear what the VA is doing.
Yeah, I think that would be wonderful. Carol, did you want to say something before we hear from the VA, or would you like to hear the VA first?
I'd love to hear from the VA first.
Okay.
Yeah, so we have our colleagues done. Thank you, Michelle. We have our colleagues, Ben Kligler and Don Voigt on the call if they want to jump in. There is experience with using this measure in the electronic health record at the VA, and I believe the VA since mid-2025 has actually sped up efforts to understand data outcomes, sending and receiving of this measure. So I don't know if any of our VA colleagues or if anyone else.
This is Dawn. I'm here. So Dawn Vogt from VA. So yes, I've seen some of these comments coming up. We've done quite a lot of work looking at the reliability and validity of the measure, and looking, for example, at how it relates to these measures like the PHQ-9, showing that it captures actually something that is quite unique from what is assessed in these disease-based measures. And Ben can probably speak more about the broader use within VA, but I can really speak to the validation process, including using it to look at trends over time, changes over time. So I'll stop there.
Yeah.
Ben, did you have more you wanted to add?
Sure. Yes, and I'll try not to go on forever. And Ben Kligler, I'm actually, full disclosure, retiring from VA, but have been leading the Office of Patient-Centered Care, which has been sort of one of the drivers of this. But I do want to point out that the comment Tom Norris just made in the chat kind of really sums up our perspective there. This has been widely used. I think in the last year, something like 100,000 veterans were screened with this measure at least once, some of them more than once. The idea, the notion that people are raising that you can hold an individual clinician responsible for someone's score on the well-being sign, 100% agree. We have no plans to do that in VA. There are just too many potential factors that are going to impact it that are outside of the control of the physician. So although I understand that, the wish to have absolute outcome measures as opposed to process measures completely, also we feel the same way, but there's a potential middle ground here with the well-being sign, which is if the way it was used is a clinician actually exploring what matters most to the patient in their encounter. So in other words, is there a well-being sign on the chart once a year in whatever given patient population, or more often if that's the right amount? And then the second part of it is you could conceivably add, from the point of view of so what, you could add, is there a documented plan or action in response to that conversation? And we are also moving that way in the VA. So it's not just about here's another box to check, but here's something that potentially changes the conversation. And so what, then we're going to take some kind of action, whether that's a referral, a specific behavior change plan, another type of intervention that might address whatever is in the way of what matters most to that patient. And we really think this is transformative in the sense of really pushing. I mean, the goal in VA of whole health has been to push beyond a strictly disease-oriented approach and staying just totally focused on disease-oriented outcomes. And this has been a really useful and important tool in getting us there. So I'll stop there. I could obviously talk forever on that. So thank you.
Yeah, thank you very much. Okay, let's turn it back to the committee. Carol.
Yeah, I thank you for the feedback from the VA on your experiences with this. I strongly support using this, particularly in primary care. And I'm saying this as someone with a lifelong chronic disease, as well as someone who has worked in various forms of home care. Because in both of those experiences, what I find is there's a challenge for providers to understand that person beyond somebody who has a condition. And I realize part of that is just there are so many pressures on providers, and I don't want to add to that. But I think speaking as a patient, sometimes providers need a reminder that there are other roles in your life than being a patient. And in working in home care, I find that often we end up having to advocate or to give information to others who see the patient, whether it's specialists or primary care people, because patients don't share that information with their providers, and then providers don't understand why patients aren't following through or why they're not listening. And so I think I appreciate the same issues, that it functions more as a way to get providers to be more focused on what's meaningful to the patients. So I'm not sure that the way it's currently being suggested as an outcome measure is really an outcome measure, but I think a simple screening like this, at least once a year, or with providers that a patient sees on some regular basis, even if they see that provider a couple times a year, could make a big difference in terms of establishing better patient-provider partnerships, and also recognizing what's reasonable to expect from a patient, and also what a patient really prioritizes.
Thank you. Jeff, go ahead.
So, well, I agree it's very important for us to hear and understand our patients. And indeed, in primary care, I think that's one of the chief tasks we have. I think a measure is very unlikely to capture that in a meaningful and actionable way. We have a lot of measurement burden already, and to add another dimension of quality of life or well-being, for which a clinician is unlikely to account for a large part of it, I think is misguided. If you want a measure to see how well does the patient report being heard and understood, or something along that line, I think that could be helpful. But I don't want to see us put this into, for example, MIPS, and incentivize people. Oh, they did a great job on the well-being score. Thank you.
Jeff, Claire. Sorry, Claire, if you're talking, you're on mute. Okay, maybe Claire's having audio issues. So Teresa, you go ahead.
So I have a lot of thoughts about this.
I just came off mute. I'm so
Go ahead,
sorry.
Claire.
You guys are
It's on
so
you.
amazing. And thank you for considering this. This has been the passion of my whole career as a geriatrician. I'm the chair of the American Geriatric Society. And a lot of the comments that have been posed here, especially our patient comment, that what matters most to me is important and should be qualified and addressed in my healthcare. So I've been part of the Patient Priorities Care team, part of the movement for age-friendly care. And what matters most is something that we can ask about with training. We need to understand how to speak with our patients, our participants, whatever field you're in, what our folks are called, but how we refer to them. But instead of seeing people as heart failure patient or the next patient with the mass or the cancer, we can find people where the next patient on our list is the one who wants to garden again, the one who wants to spend time with their special needs grandchild again on Wednesday afternoons. We can do this. I think it's going to take some training though, because you've heard some comments like, how would a clinician do that if it's not? I'm telling you, I've seen it. We can act on these things as long as we know how to ask what matters most and create actionable goals. And then I think the next step after what the VA has created, I've worked with Kay Ritchie there, who has done incredible work bringing this to the VA system. I think what we need to look towards is goal attainment scaling. I also saw some measures around the collaborate with capital RATE, where it asks, has your practitioner identified and how well are they aligning care to what really matters to you? So I think this is the right direction, but I do think there needs to be a really decent effort to teach. How is this age-friendly measure? How is what matters most going to come into real life in an actionable way? Thank you.
Great points, Claire, and thank you for kind of recentering the conversation around, what changes would need to be made to make it meaningful. I think that's really helpful. We're coming up towards the end of the time we have for this, so I want to make sure we get to Teresa, Julie, and Jan, and then after that, I'm going to turn it back to CMS to help us reflect on the day. So, Teresa, you go ahead.
Thanks so much. I want to echo Annette's comments in the chat. This, of course, risks becoming a checkbox measure if clinicians don't have the resources to address it. I think we saw some of this when we started screening for social determinants of health, that we were asking the questions and not able to provide the resources needed, especially with overloaded community organizations, to answer those questions and really meet the needs. But for me, that's not a reason not to ask the question, especially when we consider that as we're doing plans of care and as we're thinking about what matters to patients, knowing about whether they're able to do the things that they want to in their day-to-day lives is very important. And I think that's also true for residents in nursing homes and other institutional care settings, especially because we don't necessarily have built-in patient-reported mechanisms for evaluating that on tools like the MDS right now. And those of you on the call, feel free in the chat or comments to challenge me on some of this. But I think that in those care settings, knowing what's important and knowing are people living the lives that they want to be in the places they're living is an important tool for then doing something about it, which of course is the critical next step. There were a few comments in the chat about CAPS. And could this be added to a CAPS measure? I actually don't think that's appropriate because CAPS are often administered after a clinical encounter and after that patient has left, and they're anonymized when it comes to results. So it would not be actionable information for clinicians. It would be more holding them accountable for the results of this measure as opposed to actually getting information that they can use in the clinical care setting. One more comment for the nursing home setting in particular, also about short stay residents. If you are kind of in and then back out again, there wouldn't be time to even ask the question versus doing something to address that. So this may be more appropriate as a long stay measure for nursing home residents.
Thank you, Teresa. Really appreciate that context-specific feedback and also your comments on it not being appropriate to be added to CAPS. I think that's super helpful. Julie.
So since this is a
Sounds
roundtable
good.
and not, I'm going to go a little bit outside of scope and just say that I think every primary care physician would love to be able to address this and we cannot do it in a 15-minute office visit. And so if we want initiatives like this to happen, and MAHA really wants to address getting whole patient care into the lexicon, the first place we have to start is primary care payment reform. We would love to be able to take this on. One of the perks of me being a medical director and in several other entities, I was the medical director of a transitions of care clinic, and I've always had a perk of having 30-minute plus visits. And I can keep people out of the hospital with a 30 to 60-minute visit. I can do these sorts of screenings with a 30 to 60-minute visit. I can't do it in 15 minutes. And so until we address the sort of time-based billing or just broader primary care payment, we can screen all we want. This isn't going to change.
Thank you, Julie. That's good context as well. All right, Jan, and then Marty, and then we'll wrap. So Jan, go ahead.
So number one, I agree with Julie, and I'm a registered nurse, so I'm not in the provider's office, but from a patient experience, when I go to the doctor, and I'm fortunate to only need to go for an annual physical, but I also am a bariatric patient. So when my primary care physician decides to address in that annual physical, how am I doing with the bariatric weight? Am I keeping the weight off? What challenges do I have? Been fascinated with the BMI, the MCS, and the LDL conversations, all of which for me have dramatically improved. However, if my primary care physician is doing those appropriate follow-ups, so now we add a screen where they might choose to put a diagnosis code and a follow-up, I get multiple bills because payment doesn't allow those conversations to be in your annual physical. And so I have argued that and gotten some bills reversed with my insurance. But again, payment reform, one has to allow the physician time, but also from a patient perspective, if you screen and then something happens with a diagnosis code or an intervention, especially in that annual physical, the patient should not be penalized for the physician doing what is right for them. So I'm getting off my nurse hat and putting on my patient hat as someone who has been negatively affected by that payment model. Thank you.
Thank you for sharing that, Jan. Appreciate that additional perspective. Marty, I saw you put your hand down. Did you still have something you wanted to say?
Really, no. Everything that I wanted to contribute, other people have said already. So I appreciate the conversation and the passion around this. My thoughts are going to how this can be integrated into the wellness visit and other things that are already in the pipeline, like the 4M age-friendly hospital measure.
Thank you. Appreciate that, Marty. All right. So we've wrapped up our measure discussions for the day. So what I want to do is turn it back to CMS. Dr. Sharber, are there any topics that you'd like us to return to? Anything you'd like us to follow up on, or do you want to just wrap up for the day? We have about 20 minutes.
Yeah, thanks, Brennan. I realize we may get a lot of comments on my question, but you've heard a few concepts today, and hopefully you're starting to see a shift in thinking around measures at CMS that are more patient-centered, holistic, what matters to patients, and how we are actually approaching that. But what have you not heard today? What are concepts that we think are important that we're missing? And so, Brenna, if we could maybe just open that up for a few minutes to get stakeholder feedback, we'd greatly appreciate that.
Yeah, without a doubt. And if you want, maybe let somebody put that question in the chat as well for anybody that might have missed it aloud. But yeah, Jeff, go ahead.
Yeah, I think you've just heard a lot about structural and payment reform, and that's where I'd like to really.
That's not a measure, Jeff, but I heard that message.
Well, it's not a measure, but looking at how CMS can promote a team approach to care, how it can approach measurement on a more holistic level that goes beyond an individual clinician or attributing care to a small sector and broadening it, I think is a tremendous opportunity to align with MAHA rather than this focus on, oh, bad clinician, you didn't get this done or accomplished, which sometimes it feels like. So that's one thing I'd recommend.
Thank you, Jeff. And I think we've heard, agreement for that throughout the conversation. But I do want to make sure that we are also getting at the question of if we were to measure something in this arena, what would that look like? What concepts would be beneficial? Yeah, Paolo.
My audio. Across all these measures, what my feedback is that Medicare is moving to digital measures. So one of these measures should be evaluated how they translate in FHIR. And so if a measure is very difficult to translate into FHIR, that's what we are moving towards. They should not be deployed because they will increase burden. And if they increase burden, the providers will not measure it and will be ignored. So the measure will be ineffective. So whatever you do in general, you need to see if you coordinate with the digital quality measures.
Oh, spoken to the right person, Paolo. Very, very intent on the transformation to digital measures and very engaged. And I noticed your comment about aligning to US CDI and US CDI Plus and the standardization of data elements. We're actually starting to do even more work now with HL7 to do that.
Thank you.
Jan, go ahead.
So I've spent the last 26 years in public measurement from a hospital perspective, starting with the CMS core measures way back when they were AMI, heart failure, and pneumonia. What I see, two things that I would recommend is moving to digital is really important, but we do not, working with vendors is absolutely key. So if we're going to put measurement, vendors should have structured measured elements that define and support that so that there's consistency, so that when a hospital has to map and spend significant DTS, digital transformation services, resources, it is not the cost. These are not, the electronic measures are not without significant cost to an organization to maintain. So how to balance that work with a vendor for specification requirements in interoperability and CERT and all of those programs with the cost to the hospitals. Every time we do a measure, be it a CMS measure or a gold standard registry, it comes directly off the dollars that the hospital spends. I'm not saying that right, but you get my point. There is a significant electronical cost also, and we need to align that better. Thank you.
Well said, and thank you. Marty, go ahead.
Okay, hi everybody. I've really enjoyed this this time. My lens is patient safety, so I gravitate towards the prevention goals of MAHA. And with every passing year, we are getting more and better data about an opportunity to prevent harm through better diagnosis. So I'd like to really see that as a priority. I know it's really hard to wrap our heads around how to measure it, and I know there's people working on it. But this is one of the places where I think patient-reported outcomes could really make a difference, because patients and families, I think, often have the opportunity to connect the dots for providers, especially if they're, seeing multiple providers over the course of care. And the work that we're doing with patients and families, which is structured in some ways, but also just listening in some ways, shows that there's great feeling that patients and family concerns are dismissed or not heard in their visits with patients and families. And I think in their visits with providers. So really looking at the role of patient-reported outcomes in getting at this huge potential for prevention, through missed or delayed or wrong diagnoses. I think I want to put that on the table as something that's really, I think connected to our long-term prevention goals.
Awesome, Marty. And Dr. Schreiber, I've been sort of facilitating this, but if there's any of these comments that you want to dig into a little deeper or respond to, please feel free to interject.
Oh, Meredith, you know that I'm not quiet.
All right, Janice, go ahead.
Hi, this is Janice Tufte, patient partner, and I just want to say that I expect when measures were first started, like you mentioned, pneumonia and things like that, heart failure, it had to do with patient safety in the beginning and better care, right? I mean, I think that measurement should be based on better care, and I feel that today coding is such a burden, and that the well-being measure I really respected. I read the public comments, and when I read the public comments and I saw how much it would cost this one health system, I was really surprised. I wasn't aware of how much it would cost on top of how much CAPS would cost. So that's just an example. I mean, they all, add some burden, and so that's important. But I think, something to think about is how we can incorporate the patient voice and patient safety. I don't know if there could be a convening where people actually come together. This is one, but how we can really kind of rethink measure. I think like the first person measure or Paola mentioned, something about this whole thing is we're missing interoperability. It's a priority, and the DQMs are important, but we still are developing the standards behind to be able to do the synthesis and whatever for the interoperability, for fire. And it is happening. But my final comment, I'm jumping around, is AI is really taking precedent, but interoperability is even more important. I don't know a single patient that only has one portal. And so if we can't talk across portals, we're really not going to be able to address the real problems of healthcare today. Thank you.
Thank you.
It's a great point. Go ahead, Dr. Schreiber. Sorry. Okay. Jeff?
Yeah, hi. 2 points. One is I think it might be helpful to think about opportunities to leverage opportunistic screening to improve population health. So in the past, programs that tested folks for HIV when they were in front of a provider had a lot of success in identifying previously undiagnosed cases of HIV and getting people into treatment. We've run a pilot program in Maryland that looks at the possibility of A1C screening on inpatient and emergency department services. And the early results from that, which we're hoping to publish this year, would suggest that that can have some pretty significant population health benefit. And then the other thing I wanted to mention is that there is significant evidence that progress on disparities in incidence and treatment of disease by race, ethnicity, and socioeconomic status is critical to improving the country's overall health. And I know that this may not be a super popular point of view right now, but as health scientists, I think we need to continue to note that we're effectively tolerating significant morbidity and mortality if we pretend like these aren't areas that urgently need to be addressed. And so I would recommend that CMS pursue quality policies that focus on those areas and ameliorate some of those health consequences.
Sorry, I was muted. Marty, go ahead.
I'm going to lower my hand. I wasn't, I raised it by mistake.
Okay.
Yep.
No worries. Thank you. And thank you, Jeff. By the way, I thanked you on mute earlier for those comments. That's helpful. Richard, go ahead.
I'm just going to echo an extended comment that was made a moment ago on opportunistic screening. Speaking as a radiologist, this is an area where we can add tremendous value in terms of looking at measures for opportunistic screening for a spectrum, including cardiovascular disease and mammography, osteoporosis on CT imaging of the spine, cardiovascular disease on chest CTs. And I point this out, one, because it's obviously very patient-centric and aligns with MAHA, but there are numerous specialties, including radiology, that suffer from a lack of appropriate measures within the MIPS program. And it seems like this would be one where there's an opportunity to both address the MAHA issues, improve population health, as well as address more of the functional issues in the MIPS program, which is a inequity in measure availability.
Can I ask you something, Rich? How do you think the
Do.
radiology community would feel if we had a measure about radiologists asking about some of these, screenings? I will tell you the conversations have not gone well that I've had.
I think that the measure steward should come from radiology. And I think that perhaps the message needs to be, hey, one thing we would really be interested in is hearing more opportunistic screening measures, and then look for the societies to develop those measures and bring them to you. Would that be the appropriate way?
Thank you.
Does that answer your question, or am I not answering
it? It plants an idea, so thank you.
I'll take that as I'm helpful with it.
Yes, very helpful.
Thank you. Okay, Corinne.
Yes. I'm going to put a plug in for the AMA stewarded screening for abnormal glucose metabolism in patients at risk of developing diabetes. It's a diabetes prevention measure that was recently finalized for use in MIPS starting in 2026. It's a critical measure for identifying patients with pre-diabetes who may benefit from intervention to prevent type 2 diabetes and to identify patients with undiagnosed type 2 diabetes. It's clearly in line with MAHA and prevention related.
Thank you, Corinne, and I appreciate the specific recommendation. That's very helpful. Michelle.
I have a measurement science kind of comment question that's come to mind through the conversation today and in my review for the hospital advisory group over the past couple of weeks. I am very excited to see the focus on PRO-PMs, on patient-reported outcome performance measures across today's discussion and across the measures that were reviewed by the hospital committee. It's clear we're really focusing on what matters to patients in MAHA, and I think that's wonderful. As a measure developer, when I was reviewing the measures and thinking about time to value realization and appropriateness of scale, it led me to question if our definition of patient-reported outcome measures is shifting from where we've defined it previously as a disease-related outcome where a patient, or quality of life outcome where a patient is reporting a score and the outcome we're reporting in a measure is improvement. I think today we've had discussion about how, measuring the percentage of completion may be the most important thing to measure, because maybe the measure is most appropriate to use in those one-on-one patient scenarios where we're not focused on an outcome, we're focused on the process of discussing what matters with the patient. I think that's a shift from how we've thought about the endorsement and program use of PROMs recently, and it may be worth reopening that discussion on the burden benefit and value proposition for various healthcare settings and for program owners to use those types of measures. And do the criteria we evaluate measures we're putting in that category today, are they up to date?
So that's big feedback, Michelle, and helpful feedback. I think that's something, even, I don't want to speak for CMS, but I'll speak for Battelle and the PQM, that's definitely, I think, a conversation worth having, certainly. Yeah. Okay, we are coming up in our last 5 minutes here, but I see 3 hands, so let's get to those. So Mary, and then Jeff and David, and then after that we'll need to wrap. So go ahead, Mary.
Yeah, just future thought. Our organization is beginning to bring in genomics and bringing in patient genetic information that could help with treatment. And if we look at the whole patient, this could be valuable. And I didn't know if CMS had any kind of thoughts on that or any kind of future plans.
We have many thoughts, and we have people who are interested in developing the future plans around it. It's going to be a huge topic going forward, no question.
Awesome. Okay, Jeff.
So I wonder if you're really thinking about population health, why don't we have measures that look at health system performance for a geography or defined population, so that we're really getting at the wellness of a city, a region, an area that is defined as the hospital's denominator, if you will. I think that could drive performance in ways that we've been skirting around and that I've advocated around systemness that also make sure that we don't leave people behind. Those who don't come to the hospital, those who are homebound, those that have other disabilities. So this is a huge lift, obviously, but I think that would really move us forward significantly. Thank you.
Yeah, thanks for the comment.
Thank you. All right, last comment of the day, I think. David, go ahead.
Thanks. One other area to look at for expansion, especially as you're thinking of population health or fuller health and beyond the healthcare provider, is the work and partnership done with social service agencies, especially around everything that has been addressed today, plus other social determinants of health. Obviously, it's complicated with how payment, is to social service agencies versus healthcare and whatnot, but you think about a domestic violence patient as an example, who then is going to get, a lot of support, through us, that. And there's a lot of hospitals that have partnerships with domestic violence agencies, obviously around food, insecurity is another huge area. I think that's a great area where CMS can help leverage with other potential governmental agencies of how do we maximize those partnerships that already begin to exist with health systems and social service agencies in their local areas, but really strengthen, because in certain cases we have people competing for funding instead of working for funding completely. Or how do we bring through interoperability, better information to again leverage those partnerships? So if you're looking for an area to really expand, this would be exciting and game changing, in all the areas that are addressed. Not easy by any means. If I had the right answer of how to make it happen, I would be telling you. But I know I work with a lot of social service agencies, and it's ripe to really increase that partnership. Thank you.
Thanks, David. Yeah, it's great. All right, we are nearly at 11:30. So Dr. Schreiber, I'm actually going to turn to you to kind of wrap us up with final thoughts, but I will just say on behalf of Battelle, we really thank everybody for participating in this extra meeting. I know that you're all already busy with your normal primer duties, so incredibly grateful for your time and your participation this morning. I think it was a really interesting conversation. It's a little different than what we're used to. And over to you, Dr. Schreiber.
Yeah, and along those lines, let me ask folks on the line, do you like this concept of having, what did we call it, roundtables, where we kind of introduce measures that we're thinking of for the future, or concepts that we're thinking of for the future, and we have sort of a broader, more holistic comment? So if you want to put it in chat or put a thumbs up sign or something like that, we would really like the feedback, because I, for one, really enjoyed today. People had wonderful ideas, good comments. Well, I think helping shape things before we have a real an actual measure or to come to you with, shaping the conversations of directions and things to think about is really very valuable for us. And so to that, I just want to say another round of thank yous, both to Battelle, to CMS, to our partners in the federal government like GovVA, who were on the call today, to the measure developers and the stewards, and most importantly to all of you who joined the conversation and are providing feedback. What's most important is that all of this feedback helps to shape policy that helps to make healthcare and health better for all Americans. So thank you very much. And Brenna, I will close with that.
Thank you all. And for those of you on the PAC LTC committee and the clinician committee, we will talk to you later today. All right. So long.